Hi, good afternoon, everyone. I'm Mary Beth Donahue, President and CEO of the Better Medicare Alliance, and I want to welcome you to our Medicare Advantage virtual briefing. And this one is focusing on Medicare Advantage coast to coast, exploring new MA enrollment by state and district. And I'm really excited that we're going to have this opportunity this afternoon to dig into the latest MA enrollment data and discussing what it means for policymakers, advocates, and most importantly, beneficiaries. We're also going to be unveiling MA enrollment map, which we've released, and a website feature that lets you pinpoint Medicare Advantage enrollment rates by state, district, and county. And last, you'll also be hearing a thoughtful panel discussion from an outstanding group of healthcare leaders and our BMA allies. This includes Mark Mantei, CEO of the Vancouver Clinic in the Pacific Northwest, the largest independent multi-specialty group practice there. Also, we have Anne-Mary Ferrie, who's Director of Strategy and Public Policy for VNS Health, formerly the Visiting Nurse Service of New York, one of the nation's largest nonprofit home and community-based healthcare organizations. And our third panelist is Shawn Martin, Executive Vice President and CEO of the American Academy of Family Physicians, an organization representing over 120,000 family physicians and medical students nationwide. But first, let me just speak to what we have going on in the annual regulatory cycle as it continues. We have policymakers who will be confronted with important decisions on Medicare Advantage. And as these issues arise, we're here to remind you that Medicare Advantage is how more than 28 million Americans experience the promise of Medicare today. And as we're talking about enrollment today, we want to use the opportunity to remind you that enrollment in Medicare Advantage is an active choice by these seniors. Seniors are in the program today because they want to be in it. And it's not hard to see why for several reasons. MA beneficiaries save nearly $2,000 per year on premiums and out-of-pocket costs compared to beneficiaries in fee-for-service Medicare. Also, MA beneficiaries see reduced avoidable hospitalizations and readmissions. 99% of MA plans now provide supplemental benefits, such as vision, hearing, dental, and wellness coverage, while many others offer additional benefits like meal delivery and transportation. And I want to remind you of an October 21st Milliman report that confirms the federal government spends less per beneficiary in MA than for bennies of similar health status in fee-for-service Medicare. And even with those added benefits and better outcomes that we just discussed. And last, for these reasons and more, MA has a 95% consumer satisfaction rate and earned the support of a record-setting bipartisan supermajority in Congress earlier this year, thanks to your support and outreach. And you can find all these facts and more that I just shared on our new website, MedicareAdvantageFacts.com. And this is serving as a one-stop shop for the latest research and data on Medicare Advantage's value to seniors and healthcare system. So please take a look and give us your feedback. As you're going to see throughout today's briefing, when policymakers support Medicare Advantage, they're supporting the health care choices of people in their districts and states and who are their own constituents. In fact, MA, as I mentioned, is now the leading choice of Medicare in more than 120 congressional districts nationwide. So before we get to the panel of our allies, we did want to be able to have you hear from these policymakers yourself who have been supporters of MA, and it's in a short video message that Jonathan is going to play. And it's just a great reminder to hear, not see the support, but hear why these members of Congress are supporting MA on behalf of their constituents. After the video, we're going to jump right to my colleague, Greg Gear, Vice President of Policy and Research, who will give you a brief presentation of the enrollment map. So I'll turn to the video now. Thank you.
In my time in Congress, I've made it a priority to ensure that Medicare Advantage participants can get the coverage and care that provides the best value to them and best meets their needs, especially during this public health crisis. And that's why I've led the charge to call on the Centers for Medicare and Medicaid Services to protect and strengthen Medicare Advantage. And I've used my seat on the Appropriations Committee to stop any efforts to cut funding from this vital program.
But also Medicare Advantage, I think, just offers a superior product. You look at fee-for-service healthcare, I just don't think that's the way to go. It is fee-for-service healthcare. Like I said, people have those choices, but it's taking care of symptoms, where Medicare Advantage offers all the wraparound services. And I think that's just important.
So I looked at what was available and found a great Medicare Advantage plan and have been quite happy since I turned that magic age of 65 and started down this path. And this is one of the things that I like about Medicare Advantage is you actually have a lot of choices.
I've consistently supported the Medicare Advantage program, which provides quality health care to more than 27 million Americans and seniors and individuals with disabilities nationwide. Without Medicare Advantage, more than 180,000 West Virginians would be without good health care coverage, and they rely on Medicare Advantage for every day.
But I have witnessed firsthand throughout my district, whether it's in the rural areas or the urban, the value that Medicare Advantage brings to so many of my constituents. We know that Medicare Advantage beneficiaries are highly satisfied with their coverage, and I hear directly from constituents who tell me all the time, don't do anything to affect my Medicare Advantage benefits.
Well, first, it's a good deal for Central Florida seniors. We know that 98% of Medicare beneficiaries have access to at least one Medicare Advantage plan that includes vision, hearing, dental. It's popular among Florida seniors, and it helps to expand care. We know the savings, an average of $1,640 a year, 40% lower rate of cost burden.
So I think that the Medicare Advantage plans tend to be more customized and more specific, and do offer more flexibility and benefits.
My constituents love it. They absolutely love it. They love the fact that they have choices. You know what it is they love the flexibility, and of course they love the price.
I've seen firsthand the quality Medicare Advantage plans that exist back home here. They're incredibly popular. They produce good quality results at a good price, and we need to do what we can to strengthen the Medicare Advantage plans as well.
The Medicare Advantage system is critical to the success of healthcare in America.
Well, welcome back, everyone, and thank you for participating. Really appreciate the opportunity here to review the latest Medicare Advantage enrollment trends, as well as introduce the panel in a few minutes here. But wanted to just touch on, some of the highlights here in the 2022 Medicare Advantage enrollment map. This is a powerful and interactive tool that features Medicare Advantage enrollment in the states, congressional districts, and counties nationwide, all based on the latest data from CMS. 28 million beneficiaries are now enrolled in Medicare Advantage nationwide, which is really a testament to the growing popularity of the program, as well as the value it provides to beneficiaries. In fact, enrollment in Medicare Advantage now exceeds that critical threshold of 50% in 123 congressional districts, which is shown on the map here. That's up from 90 congressional districts just from last year. Moreover, 31 states now have Medicare Advantage enrollment of greater than 40%. Next slide, please. And 7 states now top 50% in Medicare Advantage enrollment. This includes states such as Florida and Michigan, with 3 states close behind at 49%, Minnesota, Georgia, and Louisiana. Looking at some of the top congressional districts on the slide here, New York and Florida are certainly well represented on the list, and going to dig into some of the details here in a minute. Next slide. Taking a deeper dive in Medicare Advantage enrollment trends, I think a few things stand out for the audience here today. Nationally, 46% of Medicare beneficiaries choose Medicare Advantage, but the projections really show increased enrollment in the program. So last week, the Medicare Trustees report came out, and they're estimating that 50% of Medicare enrollment will be in Medicare Advantage by 2026, up to 35 million. So just really showing the continued growth and enrollment and value in Medicare Advantage. 98% of beneficiaries now have access to a $0 premium plan, meaning that those who enroll in Medicare Advantage pay no additional premium beyond the Medicare Part B premium, but then also receive the added benefits of it: lower cost sharing, lower patient cost sharing, and enhanced benefits and supplemental benefits. Enrollment in special needs plans have doubled over the past 5 years, particularly with D-SNPs leading the way. And this really underscores the value of the coordinated care model, particularly for low-income beneficiaries and beneficiaries with chronic and complex health conditions. We're also seeing trends in the employer group waiver plans. They've also seen growth in enrollment, really showing the popularity of Medicare Advantage for the retiree population. And finally, virtually all plans now cover supplemental benefits. And I think everyone is familiar with dental, vision, hearing, but because of the flexibilities that have been provided over the last couple of years, both on the legislative and regulatory front, we're seeing a lot of innovation in benefit design, offering enhanced benefits to really meet the complex healthcare needs of the Medicare Advantage population, as well as benefits that address social risk factors and the social determinants of health when you look at nutrition, transportation, in-home supports, and just the dramatic increase in these benefits and the value that it's providing to beneficiaries is just very important to emphasize when you're looking at these enrollment trends. Next slide, please. Also behind these enrollment trends is really the growing racial and ethnic diversity of the Medicare Advantage population. This has been a trend that's been ongoing for some time and is really reflected in the latest data here. In fact, ethnic and racial minorities are now more likely to enroll in Medicare Advantage than fee-for-service Medicare, including Latino and Medicare and Black Medicare beneficiaries. Medicare Advantage also disproportionately enrolls lower income, those under 200% of the federal poverty level, as well as those who are dually eligible for Medicare and Medicaid. And so really what this latest data and enrollment trends demonstrate is that the success of Medicare Advantage in delivering value and cost savings to all beneficiaries, but particularly and especially when you're looking at low-income beneficiaries and those with complex chronic conditions, who are increasingly choosing Medicare Advantage that provides the high quality, coordinated care that meets their healthcare needs. So with that, just the next slide here. I just wanted to draw everyone's attention. This is an interactive tool, and encourage everyone to check it out on our website here. This is kind of a truncated way to do it. It also pops up when you go to Better Medicare Alliance website. It pops up as well, and encourage you to take a close look at it and use it when talking with policymakers. Again, it has all the latest enrollment data, again, by state, by congressional district, as well as in county level. Now I'd like to turn it to our very distinguished panel of healthcare leaders and policy experts. I'll do a very brief introduction and then really want to get into the questions and the discussion here. Shawn Martin is the Executive Vice President and CEO of the American Academy of Family Physicians, that professional association that represents over 120,000 family physicians and medical students nationwide. And Ferrie, she's the Director of Strategy and Public Policy for VNS Health, one of the nation's largest nonprofit community and home-based healthcare organizations. And finally, Mark Mantei, he's the CEO of the Vancouver Clinic, the largest independent multi-specialty group practice in the Pacific Northwest. So welcome everyone here today and looking forward to your insights and perspective. Shawn, I think we'll start with you here. I think, you think about Medicare Advantage, there's the important ecosystem and relationships between the plans, the provider, and the beneficiaries. So important when you're looking at what Medicare Advantage provides to beneficiaries as far as the high satisfaction levels that Beth mentioned and the quality of care. Interested in your perspective, Shawn, kind of what are you hearing from your primary care and family physicians about Medicare Advantage? And what are some of the reasons why beneficiaries are increasingly choosing Medicare Advantage?
Yeah, well, thanks, Greg. Thank you so much for having me. Eager to participate in this conversation, obviously with Mark and Mary as well. But I think it's a good question. I would separate the question into kind of two answers. I think on the beneficiary side, I think each of us, regardless of age, are looking for ease and comprehensiveness in our healthcare benefits and certainly in our healthcare experience. And I think the construct of the MA program, both in the way it organizes benefits, but certainly in the way that it engages with physicians and other clinicians and providers in the community, has created a more seamless experience, if you will, for beneficiaries, and it's allowed for greater innovation that's kind of responsive to how people of all ages, including those on Medicare, want to live their life and transition through the healthcare system. And I, for one, think one of the big draws that I know from my own parents is that the body is comprehensive in the MA program. So there's oftentimes vision and dental and other types of services that are available. I do think the construct of the way it engages in benefit design and engagement with the clinician and physician community is unique at the time it was founded, but it's certainly becoming a standard, if you will, in how you organize healthcare for people of all ages. And I think MA has just been at the innovative edge of that thinking, and it's very specifically on the application of that thinking in the marketplace and healthcare delivery system.
Thanks for that, Shawn. Really appreciate it. Maybe just a follow up, if you wouldn't mind. I think you were talking about benefit design and kind of caring for the whole person, the coordinated care model. When you think about Medicare Advantage and the trends there, these interesting partnerships, I think, between Medicare Advantage plans and a number of physician practices really looking to advance value-based care models and initiatives. And was wondering if you can kind of dig in a little bit, like what are some of the benefits from family physicians and primary care practices in partnering with Medicare Advantage, in Medicare Advantage, a variety of ways to do it. A lot of innovations, particularly in the primary care space. Thought you'd be good to just maybe talk a little bit about, what are some of the benefits?
Yeah, I think the benefit is really in one, obviously, in the design of the program and the design of the benefits and application of those benefits to beneficiaries. But I think really more the reason you see a lot of attractiveness of innovators in primary care delivery wanting to align with MA is two reasons, Greg. I think one is the comprehensive approach to healthcare. So I think robust, innovative primary care physicians and clinicians and groups are really thinking more in comprehensive longitudinal models of primary care. And I think the MA program is designed to be more closely aligned with those goals or that approach to healthcare. It's not built around necessarily episodes of care that often make comprehensiveness and continuity more challenging. To use technical terms, you are more likely to see capitated payment models or 100% risk models in the MA as compared to the fee-for-service program. And I think there are primary care practices that are really drawn to that. I think the second part is really on the beneficiary experience, and these innovative practice models that you speak of and we see around the country that are having such great success are really committed to outcomes that improve health and improve health maintenance and help individuals live in accordance or alignment with their individual health goals. And their approach to care is aligning with the Medicare Advantage program's design features that are really speaking more to comprehensive health, whatever that means to the individual. And I think you start to see that in some of the statistics that you mentioned. They're spending less on an individual or per capita basis. They're taking advantage of a more comprehensive approach to care. And it's just a longitudinal engagement that I think contributes. I think that innovation towards a longitudinal engagement is contributing to a better healthcare experience for everybody.
Well, thanks for that, Shawn. Appreciate you sharing your perspective there. Let's turn to Anne Mary here. I just wanted to get your perspective, particularly from your leadership position at BNS Health, and also just your perspective, representing one of the leading nonprofits in New York State. Just the enrollment map really shows that a lot of the leading districts, 3 of the top 10, are actually in New York State. And just wondering if you could offer some perspective about why Medicare Advantage is so attractive to beneficiaries in your home state.
Yeah, thank you, Greg, and thanks for the opportunity to be a part of this discussion. There aren't too many organizations that bring together so many allies together from the provider, plan, and ally perspective supporting Medicare. So thank you. I agree. It was interesting to see, the top 3 districts in New York with Medicare Advantage growth. And I would say, VNS Health, we've been providing, care in the home for almost 130 years to the most vulnerable in our homes and communities. So we've served New York for a really long time and really the most vulnerable, and have seen that value of MA grow over time and that shift happen real time. So just as background, in addition to our MA plans that we operate, including a fully integrated plan that serves the highest cost, highest need population of dually eligible beneficiaries with long-term care needs, we also offer home care, hospice, as well as palliative care and behavioral health. And increasingly, we are operating in a managed care environment. Fully 2/3 of our home care volume is in MA versus Medicare fee-for-service. So we've seen that shift. And I think in New York, we're a Medicaid managed care state, and that probably contributes, partly to that. We have a number of duals. There's a real emphasis on moving towards greater programs that coordinate and provide comprehensive care management. So that probably contributes somewhat, but I think the statistics that, you and Mary Beth shared up front really speak to the value that MA provides from a beneficiary perspective, right? Reduced out-of-pocket costs, better outcomes. We're seeing, fewer ER admissions, reduced hospitalizations, and higher satisfaction and benefits. And I just want to emphasize that point. That's particularly important for the population that VNS Health serves, the most vulnerable in our communities. In addition to, the supplemental benefits, they also support some of the health disparities that we're seeing in our communities. And it's really important to leverage, the valuable supplemental benefits that we're able to offer through MA. And I think that's making a difference. The other thing I'll just say is the increased level of engagement and support that beneficiaries get in MA versus fee-for-service. And that's especially true when we think about, dual eligible special needs plans that are within the Medicare Advantage construct, really providing that comprehensive care management for beneficiaries. So it's a number of different reasons, Greg.
Thanks for that. Yeah, Mary, that's really helpful. I want to just expand a little bit on supplemental benefits and benefit design. I know we talked about it a little bit, but when you're thinking about the increase in the offerings here, particularly when you're talking about in-home support services. Now 500 Medicare Advantage plans nationwide are offering those type of services. And what have we learned from these benefit offerings, and how does it really impact the patient and the patient outcome? I think there's just been so much discussion about the plan offerings, but really from a beneficiary level perspective and all the support and community-based services that you provide, what are you seeing as far as the impact on the patients that you serve?
Yeah, on one hand, I'd say there's the standard supplemental benefits that, most MA plans offer, which is, meaningful for members, including vision, dental, OTC. But there are other benefits like grocery that are really important for the population that we serve. And I think from a disparities perspective, it can be incredibly important, not only for dually eligible beneficiaries, but those who are not yet dually eligible or pre-dual population. So yeah, it'd be interesting to see, as we get more data, now that we know that 99% of MA plans are offering additional supplemental benefits, we can start to get some more data on the ROI there.
Thanks so much, Anne Mary. That's really helpful. I want to turn it now to Mark. We're honored to have you here today in your capacity as CEO for the Vancouver Clinic. As Mary Beth mentioned in her opening remarks, the largest independent multi-specialty group practice in the Pacific Northwest. I understand that you're up to a dozen or more locations, including multiple neighborhood clinics that are actually partnering with Medicare Advantage. And I'm wondering if you could talk a little bit more about the partnership of Vancouver Clinic and Medicare Advantage. What have you learned? How is it delivering for your patients in the Pacific Northwest?
Yeah, thanks, Greg. And pleasure to be with all of you today. We're a 450 clinician multi-specialty group practice that has kind of evolved in the shadow of the Mayo Clinic model, and have been around for 86 years. And I will tell everybody that the only way we can keep seeing Medicare patients is through Medicare Advantage. It's really the only sustainable program for our group practice. So we have over 60% of our patients that are Medicare eligible and in decent programs in Medicare Advantage. Greg, you mentioned some of our work in designing specific clinics to help take care of these folks, and we're about 3 years into that with an insurance partner. And so we have identified patients that are polychronic and are at high risk for a multitude of issues, and kind of organized our contracts with that insurance company to pay us for outcomes, which is, I think, the direction we all need to go. So let me tell you a patient story. So when we opened up our first neighborhood clinic, and we staffed these with internal medicine doctors and nurse practitioners that specialize in geriatrics, we immediately got a patient who was a veteran, had diabetes, COPD, leg amputation, just a multitude of problems. And this gentleman had, in the past year, visited the ER over 30 times and been in the hospital over 12 times. Our internal medicine team really got to know him and his caregiver. They spent an hour appointment, typically every 2 weeks. And once we began that process, that patient did not have to go to the ER or the hospital for the next 2 years. So you can see the power of, giving a medical group like ours and our clinicians, control of how we take care of patients in a model that's not fee for service, that doesn't emphasize more, but really emphasizes doing the right thing to take care of patients. And all that proactive intervention, his glucose was under control, did much better with his COPD, And those kinds of things are happening on a day-to-day basis with the Medicare Advantage patients that we're able to take care of. And I've been doing this for 35 years in group practice, and I think, and I've been involved in policy for most of those years. This is the game changer in terms of how healthcare should be delivered in the United States. So we're strongly behind it. We're opening more of these kinds of clinics so we can be a lot more accessible. And I really want to also reinforce that this has allowed us to see a greater diversity of patients. And that is very satisfying to our clinicians.
That's really great to hear, and really appreciate you sharing that patient perspective and just the value that Medicare Advantage provides as far as leading to better health outcomes, which I think is the ultimate, goal here. Mark, just to follow up, and the enrollment map, Oregon is also one of the top 10 states, just given your presence in the state of Oregon and the Pacific Northwest. We talked a little about this, but why do you think Oregon residents are choosing Medicare Advantage in these increasing numbers?
Well, I think the benefit package is very attractive, and I also think that providers have embraced it, so that if they've formed a relationship with the physician they really like, and they're seeing, the providers seeing it as a good way to take care of them, that's an incentive. So we've seen tremendous uptake in both Washington State and Oregon, and I think that it just speaks to the attractiveness of these plans. Usually there's a dental benefit, a vision benefit, some other things that go along with it, which really allows us to apply a holistic approach to their health care. And that's very powerful, and patients notice that.
That's great. Thank you, Mark. Appreciate that. I know we have a little bit of time left, so just wanted to ask a couple of quick questions for our whole panel. These will be kind of, rapid response. Feel free to jump in. As mentioned at the outset, there is a oversight hearing next week by the Energy and Commerce Committee. We know the congressional staff are listening in to today's webinar. What's the one thing you'd want kind of the committee to know going into Tuesday's hearing about Medicare Advantage in light of the enrollment numbers and the discussion that we've had here today?
I'd say don't throw the baby out with the bathwater.
You're going to say the same thing.
There's a lot of momentum here. There's a lot of good things happening. Yes, there's room for improvement, but this is an excellent chassis I used to grow up in Michigan, so I'll use an old auto term, but the chassis is right here to build on. Yes, let's discuss ways we can improve it, make lawmakers a little more comfortable with it if they've got concerns. But patients are buying into it. And, the other thing I'd mention, Greg, that I didn't get to say earlier was this is the first time in my career where I think the joy of medicine has really returned. And we have a tremendous issue right now in healthcare with burnout coming out of the pandemic. And I have no trouble recruiting physicians to take care of Medicare Advantage patients because there's a lot more flexibility in how they do things. Again, they're able to provide holistic care, take more time, et cetera, et cetera. And I'd want the committee to know that.
Thank you, Mark.
I would just say, building off of what Mark said, looking at the data is really important, and knowing who Medicare Advantage serves and what Medicare Advantage is able to offer in terms of value. And one thing I thought was, striking was that, minorities are disproportionately enrolling in Medicare Advantage. And so what that means is that you have a framework for addressing health disparities and advancing health equity. And MA plans are already starting to, work through that through, innovations and through supplemental benefit offerings, but there's more that can be done. And I just think it's really important to recognize, as Mark said, don't throw the baby out with the bathwater, but recognize, where, how, and who MA is serving. And I mentioned dually eligible beneficiaries. I just want to emphasize that point. Medicare Advantage plays a critical role in coordinating care and managing across both Medicare and Medicaid through dual eligible special needs plans for the most vulnerable in our communities, and really the highest cost, highest need.
It's a really important point. And I think when you think of Medicare Advantage and the coordinated care model, how it's been successful in closing gaps in care and actually reducing disparities in care, and what we can learn from Medicare Advantage and apply it more broadly as we all, kind of work together on advancing health equity, I think is just such a powerful statement and point. And I think just one final question before we open it up for audience Q&A here is kind of, for our audience today, what do you think is the most important takeaway that we've learned here that they can take back to their policy work and engagement going forward?
I'm happy to kick you off, Greg. I think for me, the thing that's interesting is the growth over cost. So you see tremendous growth in the program, but you don't really necessarily see an increase in costs. In fact, the data you showed today, demonstrated that the opposite may be true. You may be providing more comprehensive benefits for a lower per capita output, and I think that's a really significant takeaway. And being a longtime health policy person, the wonky side of my brain really zeroed in on that increased relationship between MA and the special needs population. I thought that was a really interesting development and statistics that I hadn't seen before, and that caught my attention.
Thanks for that, Shawn.
I think there's some really interesting things coming forward in healthcare right now that will accelerate Medicare Advantage even more. Obviously, we got the baby boom, aging into Medicare. That's something we need to deal with. But we have also learned out of this pandemic, the real power of things like telehealth and digital outreach. I heard a presentation by some colleagues on how they were able to use a hospital at home concept, keep the patient that was appropriate to stay at home and avoiding a very costly hospital admission. So there, Medicare Advantage really gives us a lot of innovation on the delivery side. And I think, that's a way that we will get control of healthcare costs going forward and improve quality at the same time.
All great points. Thank you. I think, Jonathan, we can open it up to audience Q&A.
Great. Thank you, Greg. And just a reminder for everybody that you can ask a question using the chat box or the Q&A function on your screen. Our first question in the queue is from Eric and is directed to Anne-Mary. Eric says, thanks to you all for your presentation. I was interested to hear Anne-Mary say that 2/3 of those served by BNS Health are in Medicare Advantage as opposed to fee-for-service. Why do you think that is? And are there specific elements to MA that make care in the home easier to administer?
Yeah, that's a really good question. I think, part of the reason why, we talked about, New York being a heavy managed care state. And so that probably contributes to part of it. But we talked about the value that Medicare Advantage offers to beneficiaries, and it really is a comprehensive set of benefits. So in some ways, right, for our beneficiaries who are particularly dually eligible, we're able to manage care in the home more effectively because we have coordination and oversight of really all parts of the system that the beneficiary is receiving. So that's really important for those we serve and probably contributed to some of that volume growth.
And just as we wait for more questions to arrive in the queue, I know that you had a question as well, Mary Beth.
Yes, and again, Mark, Shawn, and Mary, this has been so informative for me. So, and just also the diverse perspectives that you bring is really valuable. You know, just as Mark was telling the story about his patient, it made me think about, patients that you had, your communities or the physicians who had these patients during the COVID time. And obviously we're in a post-pandemic, but we're still, seeing the challenges, and Mark already highlighted the workforce. So as you reflect on that period of COVID, can you speak to where you saw Medicare Advantage, hopefully, helping you and those who you're representing in delivering care, or maybe where there were gaps?
So Mary Beth, I think it's a great question, and I'll speak just from a national perspective of feedback and data from family physicians alone. So I think there were some commonalities of places that responded more quickly and probably had a better practice experience from a financial and patient care perspective than others. And there were a few key things. One of them was that they were on a non-fee-for-service engagement for their compensation model. And obviously, most primary care practices that are actively engaged with Medicare Advantage are in some type of a blended or hybrid capitated type model. And that financial security really helped them respond accordingly. But I think the more important thing was just the adaptability to innovation that MA plans helped a lot of practices drive. And it's, telehealth. Mark mentioned telehealth. Telehealth gets a lot of accolades in COVID, as it should. We really accelerated our acceptance of that on both the patient and physician and clinician side. But I think there were other innovations we saw be supported and fostered during COVID that are probably equally important. And one was really in-home care. So instead of asking individuals to seek out healthcare at the healthcare site, we started to take healthcare to them in a more meaningful way. I think that's important, especially with an older population. And then the other aspect, which we hear a lot of interesting stories about, is caregiver engagement, of really, not necessarily only engaging with the patient themselves, but really starting to create a support system around those who are providing care to them in the home or on a family or relative or neighbor type basis, and the impact that had on helping a lot of people get through a very difficult period, particularly those that had chronic or multiple chronic diseases.
Thank you, Shawn. Mark?
Yeah, one of the big benefits of Medicare Advantage that we haven't mentioned is you might think that everybody knows who their patients are. That is not the case in a regular Medicare system. But with Medicare Advantage, we align that patient with a primary care provider, and we know who our patients are, and we get them in annually to understand their chronic conditions and all that stuff. So in the pandemic, we basically had to furlough for 2 months a whole bunch of doctors because we couldn't see patients in the clinic unless it was absolutely emergent. And what we had those folks do was reach out to all our MA patients and check in on them. And they had their records. They were able to say, oh, you've got CHF, and I know you can't regularly come in, but let's have you weigh yourself every day, and you contact me if there's a big change or whatever. So this, the whole idea that you get folks, you still give them choice, but they're really aligned with somebody they trust, makes a huge difference. And I think we were very successful in getting our patients through this.
I would just add to that, from the, I mentioned, we're a dual eligible special needs plan and a fully integrated DSNP as well. For us, I mean, our population was disproportionately impacted by the COVID pandemic. We know that, duals had higher hospitalization rates than the non-dual population during the pandemic. So this is a really vulnerable population, many of who are homebound. So one of the innovations that we were able to do was bring vaccinations in the home. They couldn't go to pharmacies. It was really, really important that we were able to provide, that level of engagement and support. And as Mark mentioned, I mean, we're not just paying claims, right? These are really important relationships to build and to meet the member needs.
Thank you, Mark and Mary and Shawn. Jonathan, I don't know if there's another question. I was going to do a follow-up, but if there's a question from the audience, I want to obviously defer to those attending.
Sure. We do have just a few other questions that have trickled in here, so we can ask those real quickly. We've got a question from Gail, and she says, are the younger Medicare eligible signing on for Medicare Advantage plans?
That's a good question. I think a couple things here. Our research actually shows that as far as age, Medicare Advantage and fee for service are about the same. So it's not really that younger people are enrolling. There is sort of like a caveat there is that for the more people do enroll in Medicare Advantage due to disability. So that could be, kind of a consideration there. And I guess at the front end, when people become Medicare eligible, research shows that only half of beneficiaries are aware of the option to enroll in Medicare Advantage. So a number of different factors here, but bottom line is kind of our research shows that there isn't really major age differences between the Medicare Advantage population as compared to Medicare fee for service. They're roughly about the same on average.
We've got another question also from Eric. I believe no relation to the earlier questioner. And he's with Congresswoman Jamie Herrera Butler's office, one of the members who signed the annual Medicare Advantage support letter. And his question is for Mark. And he says, how has Medicare Advantage positively impacted the residents of Southwestern Washington, including rural residents?
Yeah, Eric, thanks for that question. And thank you for Congresswoman Herrera Butler for her support all these years. Number one, access. I think it's improved access because the regular Medicare program in the state of Washington really wasn't financially sustainable for a lot of physician groups and provider organizations. Getting in Medicare Advantage has improved accessibility to healthcare for a lot of people. And I'm glad you brought up Southwest Washington because that's my home. And, we're really proud that it's allowed us to expand. So we're reaching out to more patients in Cowlitz County, for instance. And I think, there's just tremendous potential to do even more, especially with these neighborhood clinics that we're starting to open.
We've got another question from Thomas. He says, and I believe this could be directed to any of our speakers today. He says, could you speak more specifically about why Medicare Advantage is better situated to drive value-based care as compared to fee-for-service Medicare? Is it because of aligned incentives, market flexibilities, or another reason?
I'm happy to take a first run at that. I think it's a comprehensive approach to care, and I think I often speak of the outputs of what that means for primary care, just a comprehensive approach to primary care. But I think it's really more sophisticated than that. It's a comprehensive benefit package coupled with a comprehensive approach to network design and inclusiveness of physicians and clinicians that provide a complete healthcare experience for the beneficiary, and that experience becomes important for upstream impact of compliance and engagement and prevention and all the things that ultimately lead to better health and lower cost from a programmatic standpoint. So, fee for service was designed at a different time under a different set of expectations. And over time, we learned that the pursuit of comprehensiveness really was a better approach to care, particularly for those that are active or, high utilizers of healthcare. So for me, it's a design feature.
Yeah, and I'll chime in. A fee for service has perverse incentives, I think, in a lot of ways. And, you're basically rewarding more regardless of the value that it adds in many cases. So we're large enough that we can take accountability and take, a portion basically of the healthcare dollar and manage that. And having a long-term view of that patient, if it, like this summer, it's going to be super hot. If that patient needs an air conditioner to avoid an ER visit and dehydration, we have the flexibility to do that. There's just all kinds of, innovation that can occur with the folks that know the patient the best. And I'm a huge advocate for moving in this direction, because it really results in better patient care and like I said earlier, more holistic care.
Don't really have much more to add to that than what Shawn and Mark mentioned, but I would just say, I agree that I think it's a level of managing that care with the aim to keep our members healthy and reduce avoidable hospitalizations. And when you have VBP structures that include two-sided risk arrangements between provider and the plan, there's really an opportunity to advance VBP and reduce cost. And we've been successful as a home care agency. Over a third of our Medicare Advantage contracts are in these two-sided value-based arrangements. And we've seen, good outcomes from that. We reduced 90-day readmissions by a third and reduced total cost of care by over 10%. So there's really an opportunity in working with Medicare Advantage plans in these types of arrangements. I think some parts of the industry, may be slower and there's some more work to do, but I think all signs are pointing towards a good direction.
Just to add one more flavor to this, we figure that an avoided ER visit pays for about 10 primary care visits. And that's just rough numbers, but still you can see the power of that. And an avoided hospital admission, it's probably 50. But we're really seeing the power of more frequent interaction with the patient that needs that attention in a primary care setting, with the right involvement of specialists, et cetera. Really reduce the need for hospitalizations and ER visits. And that's where the system can save a lot of money, improve quality, and improve patient satisfaction.
Yeah, Mark, our statistics are similar. We're about 8-to-1, 99214 to an emergency department visit for undifferential diagnosed illness. So, you can go up from there, but it's really a stark statistic of you can send somebody to see primary care or some type of community-based engagement almost every month, and it's worth it because of the upstream cost and the benefit to their health and health maintenance.
Mary Beth, we've got just a couple kind of specific questions in the queue that we, Better Medicare Alliance, will be reaching out to folks individually after this briefing to answer some of those questions. A couple questions about the functionality of our website map, and so we'll talk to those folks individually. But I believe we can transition now to any other questions you have, and then closing remarks.
Great. Well, I'm seizing the opportunity in just a couple minutes left to get another question in of my own. So thanks, Mark and Shawn and Mary, for indulging me. Again, just as we were talking about, COVID and the role that MA was able to play, and especially in serving populations from communities of color. As we look ahead, what more do you think Medicare Advantage can be doing to serve those communities and again address gaps regardless of how MA is able to provide access to care for more Latinos and African Americans than fee for service?
I think it's a great question. It's probably another webinar, so I will be brief. I think there's a couple of things. I think one is really engaging in what I would call the equitable distribution of the kind of foundation of healthcare in the 21st century. So access to broadband, making sure that communities that you're trying to impact and have outreach to really are being brought into an equitable place where they can receive healthcare and healthcare benefits in a similar way to citizens in other communities. But I think the biggest thing for me, Mary Beth and I shared with you before, is really concentrating on extending reach into counties and communities that may otherwise have not had access to Medicare Advantage plans in the future, and how do we create a policy framework that makes that more possible for more people. And I know that's easier said than done in some respects, but I think that's a place that we could all have some shared goals.
Thank you, Shawn.
Yeah, we've had a particular emphasis lately on trying to reach more of our DSNP population that's not well managed in terms of their health care. And, I've really discovered that there's nuances to a lot of different communities. You've really got to be a lot more open in terms of how your website's designed and multilingual. And we're working very hard on that. I think it's an area where we're going to see a lot of progress in the next couple of years.
Yeah, I would agree with that. We actually just had came out of a meeting with CMS leadership, and we talked a lot about the importance of making sure that options are easily understood by all beneficiaries. And I think that's a continued challenge, especially for the duals population, given the fact that choice is important, but there are so many options, and it's hard to understand which one provides the most level of care management or benefits and support. So I think there's more work that can be done there.
Great. Well, Anne, Mary, Shawn, and Mark, thank you again for allowing me to indulge as we were getting close to the time. And, as Shawn said, there's more discussion. So there's nothing better than having a webinar where we know issues that we can talk about in our next one. So thank you. All right, well, we're going to close. Sorry, we're just 1 minute over, but just want to remind you to remain in touch with us. We have that new one-stop shopping on our website that we spoke about earlier on the Medicare Advantage facts. And then please stay in touch with us on Facebook and LinkedIn and Twitter.